Thanks everybody for joining us, and welcome this evening to our session on deferred care, cardiovascular disease, diabetes risk and cancer screening. So this is the second in our three-part series on deferred care. The first part ran last month, and there'll be another session that will be a little bit later in the year, so keep a lookout for that. I'd like to start by acknowledging that we are meeting on the lands of the Wurundjeri Woi-wurrung people, the Boon-wurrung people and the Wathaurong people here for me in Melbourne, and to pay my respects to elders past, present and emerging, as well as to pay respects to any Aboriginal or Torres Strait Islander people in the session with us this evening. Very quickly, some housekeeping for the session. So everyone who's attending is muted, so don't worry if you can't speak, that's why. We will have a section at the end for question and answers, so please put your questions in the Q&A box. The questions will be anonymous, and we'll at the session at the end, we'll be reading out the questions, and you'll have the opportunity to ask those to the panelists. This session is being recorded, and as it says there, the questions are anonymous, so don't worry that they'll be recording who's asked which questions. And finally, please join the session with the name that you've registered with. So this is so that we can mark your attendance for CPD points. So if you've joined the session on your phone or on somebody else's computer and it doesn't reflect your name, please change that name on Zoom so that we can record your attendance. There's a very quick overview here of how to change your name. If you get stuck, Phil, who's doing support for this session, can help you. But if you hover over the Zoom window, you'll have an opportunity to rename yourself. Just a short disclaimer, things change a lot at the moment. So just be advised the information in this session is accurate as of today. So I'll very quickly introduce our two speakers for the session tonight. So Dr. Ralph Autumn is the first speaker, and he's a GP with over 25 years experience, and is an honorary clinical associate professor at the Department of General Practice in the University of Melbourne. He's got a long-standing interest in chronic disease management, especially diabetes and heart disease. Our second speaker tonight is Natalie Simpson-Stewart, and she's an experienced practice nurse with 15 years of nursing experience in various settings, including defence, community settings and primary care. And Natalie has a passion for chronic disease management, using digital health and tools to efficiently manage patient care, and has a long-standing history of successful immunisation clinics. So thank you to both our speakers. A very quick overview of the agenda for today. As I said, we'll have Dr. Ralph Autumn starting off, talking about deferred care and the issues, and then Natalie will take us through a bit of a deeper dive into the challenges for chronic disease and cancer, and then some strategies for really finding those patients and re-engaging them for ongoing care. And at a very high level, these are the learning objectives and goals of this series, this deferred care series. So I might pass over to Ralph now. I'll stop sharing my screen. And Ralph, you can share your slides.
Well, thank you, Michaela, for all of that. That was all very nice. And thank you for asking me to talk about this, because it is an important emerging issue that's actually happening. And look, please, for the audience, please ask questions. There's no such thing as a silly question. These sort of things are always much better if there's interaction. So if you do want to find something, please type away in the question and answer box, and then we'll get to it, because the more you ask, the more we'll get out of it. So look, I'm coming, and look, as I'm sure everyone else here is, that the last couple of years have been particularly challenging, and the challenges are still going. You know, we've recovered from a week where we had 2 GPs away with COVID, so I know the pressures that are actually happening. But those pressures, other than COVID, are starting to show up in a lot of the other things that we do. And today, I mean, we're talking about diabetes, heart disease, and cancer. And of course, we're now expecting a surge in diagnoses that are coming forward. So we know that COVID in its own right had a big impact on people's lives. And you can see our comfort food, potato chips, red meat, sugary drinks, they all went up. And this is, I'm seeing this in my patients. A lot of my patients put on a lot of weight. They were sitting home, and of course they were sitting home and working at their computer, then they were watching their TV. And so screen time actually increased enormously. And of course, they were no longer commuting in and out of the office. So a lot of the incidental activity was also going down. And so in many ways, it actually created a perfect storm. People had ready access to foods that maybe they shouldn't have been having ready access to. Activity was going down significantly. And when I talk about significantly, the decrease in the amount of exercise that people did actually just plummeted at the very beginning of the COVID outbreak. People just stopped doing things. And, well, got to be careful how I say this, but it's often hard enough to encourage people to be active at the best of time. And now they had an excuse for not going out. I've managed to lose one. Someone's changed the order around. Sorry about that. So I've missed a couple of those slides. I'm sorry, but certainly that last one is looking at A1c. And the number of A1c tests that have been done dropped by 75%. Now, if you think about that within our diabetes population, not doing the A1c, that suddenly is a big issue. And I'll explore a little bit more about that later on. But it became such an issue that people are now starting to get worried that we're actually going to see a surge in preventable illnesses, things like malignancies and heart disease. And certainly we've had people who were rocking up to emergency departments well beyond the time that they should have with acute coronary syndromes. And so interestingly enough, though, despite all this doom and gloom, in the beginning, there was an actual reduction in deaths. So you can see that there was around 2,000 fewer deaths in 2020. Now, there's always variations in the way they manage it, but the original impact was actually a reduction. And then as we went through 2021, we started to see an increase. So there were 5,100, but again, they do their statistical analysis and it wasn't that much of an increase. But then suddenly in 2022, the first 2 months, there's been a big surge in deaths. The COVID-19, is having an impact. So even though the actual virus itself may be less virulent, because so many more people were being infected, we're seeing a lot more people end up in hospital. But we're now starting to see a surge in heart disease. So that was a third higher, dementia, other sort of respiratory conditions, think asthma, COPD, stroke, and diabetes. Now, it's interesting, look at that number for diabetes, because later on I'll show you some seasonal trends around what's happening in the death rates over the time. And diabetes is actually coming up as a very strong surge in deaths. We also know that distress amongst people through COVID is certainly happening. And, it was certainly reflected in along with our young people, but I saw it across the whole population. There was certainly an increase in anxiety, increase in depression, as all the usual things that we did to keep our health and, keep our, restore our sort of mental health was taken away. So, you couldn't go out and exercise, you couldn't socialize. And so people felt worse. And I'm sure all the GPs and nurses out there have seen an increase in the number of people with depression, because I can certainly say that the number of mental health care plans, especially over the last sort of 9 months, has really gone up. As this whole sort of thing has taken its toll on people. So it's actually impacting almost every part of what we do. Now, this is looking at mammograms. Now, you can see that initially there was a huge drop in the mammogram, and that's because a lot of the breast screen centres actually closed down and they weren't taking patients. But as you can see, there was a little bit of a rebound. So sort of getting back to those pre-levels where they were. So, that was at least good to see that there was a recovery. When you look at PSAs, so this is screening for annual PSA, you can see again there was a big dip over that April-May period, but then it's actually gone back, overshot a little bit, and now it's actually back to where it should be. So again, whether you subscribe to PSA screening or not, it was certainly something that did show recovery. But now this is looking at colorectal. So people who've had either a change in bowel habit, PR bleeding, or a positive FOBT. And you can see that the colonoscopes are still lagging behind, certainly well below the 2019 levels. And that has enormous consequences, as we'll talk later on, because, if these people have a cancer and we're delaying the colonoscopy, that means we're going to be diagnosing people at a much later stage. And of course, their prognosis drops accordingly. So, again, that should be starting to ring alarm bells, and we may not see the result of this for some time as yet. And, the colonoscopy waiting times are still way out at the moment. And these are the actual interventions for people with prostate cancer. And again, you can see it's still quite a long way down from where it should be. So, does this mean that we're not picking up on prostate cancer early? Is it that means people are deferring their care? So these are sort of all adding up to that sort of perfect storm of, delayed diagnosis, and what this talk's all about, deferred care. And deferred care has consequences, which hopefully the fact that you're here, we're going to do something about. And that's going to be very practical, because we've got Nat to actually talk about what it is that we can do. And so this is what everyone's saying, that we're expecting a substantial increase in people to be diagnosed later than what we have. We can see that people are urgently looking for policy interventions to try and make sure that these cancer screening services are available, and try to, get that backlog of things like colonoscopies done, and so that we get people back onto an even footing. And you can see the impact, even a 3-month delay in a cancer diagnosis would result in 90 additional deaths, and a huge cost to the government. So it's actually within their interest to do something. And a 6-month delay in cancer diagnosis, an extra 350 deaths. So this is something that's actually important that we do think about, and start to think about what it is that we can do to try and blunt this impact that we're having. And look, it doesn't help, I know, having code browns within our public hospitals, but we need to think about ways of what we can do for people that we have a real concern for. And it may end up being picking up the phone and advocating on their behalf as well. And you can see here, I'm I mean, I think the uptake of telehealth, I think that has been very useful because not everyone needs to see a face-to-face. I mean, I'm old-fashioned and I've managed to incorporate the telehealth within my normal routine. We've been seeing people face-to-face throughout the whole COVID outbreak, and it was actually most of our patients that were deciding to go telehealth. But, you know, there are still important things that you still need to see face-to-face, and we've got facilities within our practice to do that. But 43% of people cancelled appointments. Now, sometimes that was with specialists, or even some of our outpatients cancelled appointments for follow-up. And, you know, people were avoiding new appointments, even though they knew something was wrong. So, you know, again, you can see it's sort of building up this whole sort of concept of we're in for a trouble. And, you know, even though there were fewer deaths amongst everything, I will talk a little bit about the diabetes side of things, because, I mean, most people will know I'm really keen when it comes to diabetes. So this is looking at, you know, I was actually surprised when I saw this article, is looking at the expected deaths versus the observed deaths. And I never realized that there was such a seasonality in our number of deaths. I mean, I always realized in winter there was going to be more respiratory deaths, but this is actually really quite marked. Now, so if you look here, this is what we saw was to be predicted total number of deaths between 2020 and 21, and you see it just didn't eventuate. And look at this, you know, we really expected lung problems to, you know, to continue, but my God, it was really fantastic. And let me say, I'm sure a lot of this had to do with the isolation and the fact that people weren't getting all these illnesses, you know, because they were being basically not being exposed. And you can see over here, in fact, you know, the big drop in pneumonias. So, and, you know, I mean, I know we're paying for it now because we're seeing so much of the flu and some of the other respiratory viruses. Ischemic heart disease was a little bit of a drop. But here, you can see, whereas with diabetes, this was the number of expected deaths, and you can see that in people with diabetes, there was actually an increased mortality, which, you know, wasn't replicated in all the others. And I'm sure a lot of that was because of deferred care. And we can talk about podiatry, we can talk about, you know, eye checks, we can talk about blood tests, and the fact that, you know, so many of the A1Cs weren't being done. And so this is now looking, so just unpacking the diabetes story. I just thought I'd pick, you know, the diabetes foot service. So these are people with high risk feet. We know that people have high risk feet, and if they have a problem, it does put them at increased risk of death. And you can see here that the length of hospital stay certainly decreases in Turkey. And this is actually looking at activity within a specified, you know, highly sort of centralized diabetes foot service. But you can see here that the referrals from outside dropped absolutely dramatically. The average A1C was much higher, so people were obviously not being treated as aggressively. The Wagner grade, which is a measure of how severe the high risk foot is, you know, how high risk it is, and that people were presenting later with more advanced disease. And so interesting, the number of people going for debridement actually went down, but amputations actually went up, which is a real tragedy, because we know at least 50%, if not more, of diabetic foot amputations can be, you know, prevented. Italy, it was much the same. So again, the proportion of people coming in from outpatient dropped down because people just weren't going there, but the number of people going through emergency skyrocketed. So again, people were waiting far too long before they attended. The gangrene, so people were presenting with gangrenous pose. I mean, you know, a real tragedy. And the proportion of patients, again, you can see the huge surge in amputations. Again, a real tragedy. So it was a 3 times greater risk of having an amputation, you know, during the COVID time than it was beforehand. Now, interestingly enough, Canada, a little bit different. So they implemented a very strong telehealth response to assessment of diabetic feet, and they brought out some guidelines very early. So despite the fact that they weren't seeing people face to face, and people were avoiding hospital, there were no excess leg amputations seen in Canada during the first 11 months. So, you know, I think that was because of what the system that they put in place to capture people and doing a lot of online and telehealth. And so this is, of course, where I'm coming to, that if we can pick people who are at risk and actually start putting a plan around them, maybe we can stop a lot of the heartache. Heartache in terms of excess ischemic heart disease, amputations, and diabetes deaths. And the reason why I brought this slide up is this is looking, especially this area here, is looking at the proportion of people who can get their A1c to target as a proportion of where they started. So you can see if you start intensifying therapy in someone who's got an A1c under 8, you will get most of people at target, you know, less than 7, which is great, and which is what we really want to be achieving. But if people are deferring care, not having their A1cs, and we're not quite sure where they are within their trajectory, if they're coming back with A1cs, let's say between 9 and 9.5, the chances of you getting them back to target now with all our wonderful medications is actually less than half. And we know that has serious complications in terms of, you know, kidney disease, eye disease, and feeling terrible. So again, when you think of those number of people that that reduction in A1cs, you know, we can't afford for people to fall down this cascade. We need to really be thinking about capturing them nice and early. So, which is one of the reasons why I'm glad that we've got Nat here, who will be talking a lot about how we find people who've been missing out on care. So again, within Australia, the ACS, you know, it was interesting. The volumes of ACS were much the same, but there was a 4-fold increase in the symptom to door time. So we know time is heart muscle. And so it was taking people much longer from the time that they developed chest pain to actually getting there into the cath lab. Now, again, you know, part of that would be and you know, I've had patients admit, oh yes, I should have gone to hospital earlier, but I thought I'd wait just to see what happened, because they didn't want to go to hospital and catch COVID. You know, and here they are sitting with a heart attack. So, and the fear out there regarding the COVID versus other things, it was in many ways disproportionate. But, you know, interestingly enough, there was a reduction in hospital admissions or, you know, presentations for heart failure, but those that did presented much worse. So much with a much higher the New York Heart Association. So again, people were waiting far too long before they would do something. And again, we need to start picking up on these people to make sure that they do get the care that they need at the right time. Because again, the longer they wait, the harder it is to actually rescue them and to improve things. And having a think about what we're going to do with our patients now is really important, because COVID is not going to disappear anytime soon, sad to say. And things like cardiac rehab. Well, see, many of the cardiac rehab services were shut down. We know that actually people who've had an ACS who attend cardiac rehab have a 50% less mortality over 5 years. I mean, that's been known for ages. And here they shut down cardiac rehab. There was some limited offering online rehab, cardiac rehab, and I know the Heart Foundation tried to put one online, but a lot of people missed out on life-saving therapy. And cardiac rehab is certainly one of those. But, again, things like the mental health meant that people weren't focusing on their health as much, and it was becoming more challenging. And look, the hospitals themselves weren't immune. So the in-hospital mortality actually went up as well. And those hospitals that had a reduction in admission rates for things like ACSs, they had a greater in-hospital mortality, which again tells you that people were turning up too late. The horse had bolted and they hadn't got there in time. And we know early intervention is really important. So again, stressing to our patients as they come in that if you have angina or heart pain, you call the ambulance. That's still really important, because what we don't want is people going into hospital later than they should, right? With heart disease, because we know we can reverse it if we get them early enough. But obviously that message is not getting out. So that's sort of where I'm going to stop, and I'll stop the share. But what I'd like you to think is, now when you're listening to Nat speak, what I'd like you to do is think, have I done enough in terms of picking these patients that are at high risk? Because the people we have people who manage their health really well, and they will continue to do well. But there's a large group of people that often just need a little bit of prompting to ensure they get the care that they need. And are they the people that we're now missing? And how is it that we can maybe identify those patients, get them in, and make sure they then start re-engaging with their health and getting it back on track? Now, so that's it from me. I hope you found that useful. But look, the really important part, so mine was really setting the scene. The really important part's coming next, is the how to do, because really applying, this sort of information and saying, well, what are we going to do about it, is really key. So, Michaela, thank you.
Thanks, Ralph. And everyone, remember, you can pop your questions in the Q&A if they're coming up as the presentations are going on, and we'll get to them at the end. Or, of course, you can pop them in at the end. So now, thank you, Natalie. I'll ask you to share your screen and start your part of the presentation.
Wonderful. Thank you so much. I always enjoy listening to Ralph's presentations. They're always interesting and actually applicable to what we do day to day, which are always really nice. So let me bring up my very wonderful slides once it wants to behave itself, because sometimes it doesn't. There we go. Come on, stop it. Share that one. I'm a millennial who's not as technologically savvy as I would like to be. You'll have to forgive me. So let us have a look. Here we go. Where is slideshow? Okay, so I thought I'd start by doing a little bit more of a location specific to the Northwest Melbourne PHN overview of what Ralph has so kindly gone through for us. So our first presentation, which was a month ago, was on younger people, and that was looking at sexual health immunisations. So that one's available on the PHN website. So this one more towards the, I'm going to say middle-aged, and no one be offended by that, please. So we're entitling it people who like Kate Bush the first time around. So having a little bit of look at heart disease and diabetes, and also cancer screening separately. So I thought I'd have a little bit of a look to begin with. Risk factors over COVID. So we know that people accessing healthcare certainly dropped off. We all felt it, particularly that first year. What people were doing at home was not conducive to health for the most part. And I feel like we're all in that basket as well. So as Ralph mentioned, we all turn to comfort foods and snack foods. So particularly women were more likely to be picking up the snacks than men. I think we all lived through sourdough gate of 2020. So there was an increase in people cooking at home, baking. Interestingly, we saw a reduction in takeaway. And I think this is a really big thing for people, both through lockdowns and then in that working from home period. People weren't as time poor. Their ability to actually cook for themselves increased. So yes, we were eating more snacks, but when we were eating meals, generally they were home cooked meals. Quality thereof, not with physical activity. We all moved less. That's just standard. We all sat there and watched screens a lot more and didn't go outside for the better part of a year and a half. When they surveyed people and asked why people weren't exercising, two big reasons. So one was lack of motivation. Just people were not keen to move. The incentive wasn't there. You couldn't go do stuff with people. And why am I going to bother? The other big thing was people not wanting to wear masks while exercising was a big move too. So there is a little bit of a barrier there. We did find, though, on the opposite to diet side of things, men's physical activity dropped more than women's. And what we know with physical activity trends is men tend to participate in group sports and group activities more so than women. Women tend to do more solo walking, Pilates, yoga, home exercise programs. So the ability to participate in regular exercise was easier for women than it was for men, even though we saw a decline overall. Alcohol consumption. Dan Murphy's did very well over the pandemic. So interestingly though, there was evenish numbers around 14 to 17% in both in people who drank more and in people who drank less. So for people that drank less, they couldn't go out. They couldn't hang around with who they'd usually go out drinking with. They took lockdown as an opportunity to improve their health. Remember lockdown 1 and 2, where we actually were incentivized and felt motivated to do things that were better. For people that did increase their drinking, more time at home, they were bored. They didn't have anything else to do, and that was men, whereas women reported that they were drinking more because of stress. Smoking. Again, little bit of a, even Stevens in terms of people that smoked less and people that smoked more. People that were smoking more were bored, stressed, and had more free time to put a cigarette in their mouth. Again, people that were smoking less, they were wanting to improve their health, so really taking that time to do something proactive. Also, less opportunity to smoke at home. So the influence of discouraging housemates or family members played a big part in people cutting down their smoking. Now, this graph I've got here, I think the interesting thing that we look at is when we look at daily smokers by age group, and particularly the focus of this webinar, we're looking at that middle age group. We know that it's an increased risk factor for diabetes, heart disease, cancers. We know that we start to see these things here, and around that 45 to 55 age group, those daily smokers really start to pick up. So the age group that we're looking at tonight are also the ones that we really need to be nailing onto these risk factors post-COVID. Mental health, we've all felt it. It all went up during COVID, not surprisingly. What we know about mental health is that there is a link between depression and cardiovascular disease. Big part of that is if you're depressed and you're amotivated and, functioning is too difficult, your desire and ability to engage in proactive health, it's not there. It's not even on your radar. Maslow's hierarchy of needs, you are on that bottom rung. People with severe mental illness, so psychosis, bipolar disorder, schizophrenia, the major depression and delusion disorders, they already had pre-existing higher rates of metabolic syndrome. So around 2.5 times that of the general community. Again, partly lifestyle factors, partly economic factors, particularly for people that are unable to work as a result of their illness. Also medications, there's a lot of those antipsychotics that also increase the risk of diabetes and heart disease as well. We know loneliness and isolation are linked with high rates of heart disease, and we've all felt a little bit lonely and isolated over the last 2 years. So looking at patterns of what happened with mental health over the COVID pandemic, people that already had and were struggling with mental health, it got worse. That goes without saying. Social isolation, so even people that would have been relatively engaged in their community, that really dropped off. Inequalities of access to healthcare. And we all feel it now, the amount of people that are struggling to access mental health care, it's huge. I have touched on mental health a lot more in the previous webinar, so if you're wanting some more information about resources, it's well worth going in and watching there to get focus on this a bit more. So looking at, we know risk factors got worse. Picking up people who are at risk of these diseases. So heart health check items, it's estimated that we did 27,000 less over that 16 to 18 month period during COVID. So that is potentially 27,000 less people that are aware that they're at an increased risk of heart disease. It's not ideal. Interestingly, looking at the data that actually predates COVID and then through COVID, people that were surveyed between the ages of 45 and 74, 2/3 of them hadn't had a heart health check. However, half of that cohort had either previously been told that they had medical risk factors for being at risk of heart disease. So when we know that that risk is there, we're still not making use of that item to really knuckle down and focus and engage people in their risk of heart disease. Diabetes, HbA1c's dropped off a cliff, both for management and screening purposes. We know that diabetics reduce their engagement with both medical and allied healthcare. And looking at the systematic reviews that are starting to come out now, glycemic control, terrible. Visual, those people with diabetic retinopathy not seeing their ophthalmologist, we know that visual acuity is actually worsening across the board as well in our diabetic patients, which is not ideal. So that lack of engagement comes both ways. Obviously, Code Brown, there was severe limiting of services. A lot of hospital things were postponed. Particularly the Alfred, they really noticed that as soon as another lockdown was announced, the amount of calls to their outpatient department, people deferring or cancelling their appointments, increased exponentially. Diabetic foot care, as Ralph mentioned, terrible, worldwide. We're struggling. We need to bring it back, people, and start getting back on track with this routine care. So looking from a Northwest Melbourne PHN perspective, so why do we need to care in our catchment? We know people that are from culturally and linguistically diverse backgrounds have more challenges with accessing care. 44% of our population in our catchment was born overseas. We have a very significant called group that we need to support to access care. We also have significant pockets of lower socioeconomic status. So we, in our PHN, actually hold most of Victoria's bridging visa holders, and we have more humanitarian arrivals than any other PHN in Victoria. We also have higher levels of disadvantage in our local government areas compared with the other PHNs in Victoria. We're also a huge growth corridor. So by 2036, so 2035, we're on track to eliminate cervical cancer. 2036, we're on track to have 1/3 of Victoria's population. It's huge, the amount of care and the amount of people that we're going to be looking after in the next sort of 2 decades. So where we're sitting at the moment in terms of heart disease and diabetes. So this is really interesting information. So graph on the left can be accessed at the Heart Foundation website, graph on the right through Diabetes Australia. So what we can see is that for our geographical location, our catchment area, we have more people that disengage from education early. We have higher amounts of people that don't have internet access. We have higher rates of people that don't have a reasonable standard of English proficiency. So there's big barriers to accessing care that we have in higher rates. We can also see that we have higher rates of hospital admissions related to heart disease. We have significantly higher rates of risk factors than when we're comparing it with the rest of Victoria and nationally. Diabetes wise, we have a significant proportion of diabetics. I don't think that comes as a surprise to anyone, particularly when I go through the Oz risk calculator, this will become more apparent. So Ralph has mentioned, if we catch people early and we manage their glycemic control early, we're more likely to get them to target early. The thing that we know too is for people that not only get to target, but stay very tightly on target, particularly in that first 5 years after diagnosis, generally their rates of poorer outcomes in terms of microvascular complications is significantly better. So even if they fall off the wagon later on after their diagnosis, that first 5 years and getting people to target and keeping there is really important in terms of preventing issues, you know, renal failure, diabetic retinopathy, foot ulcers, all the rest of it. So it is important. So start them early, get them aggressive. Cardiovascular disease, rehab just didn't happen. So potentially in the next 5 years, we've got all these people who are now at a higher risk of mortality because they didn't attend cardiac rehab. That's a significant number. The other thing we are still watching is what happens to people post-COVID in terms of heart. We don't know. It's still early days. We are lucky in terms that our rates of heart disease post-COVID infection are lower than other places in the world. However, then we've got sunk by Omicron. So this is to be continued. We'll still watch the data with this. The other thing we know is that respiratory viruses are back, baby, and they are back with a vengeance. So particularly with influenza, we know in people with underlying ischemic heart disease, those that get flu generally have heart attacks at about a rate of an increased 50%. So this is why flu shots are important for your patients with heart disease. But what we're going to see is now with the return of all our respiratory viruses, we're also going to see a return to those ischemic heart disease mortalities that we've missed out on in the last 2 years. So moving on to cancer screening. So just a bit of an overview of what happened during COVID. So that first lockdown, when we all had a really big panic about COVID initially, they actually closed Breast Screen Victoria for just over a month and a half to 2 months. Nationally, there were closures, but they weren't as severe as what happened in Victoria. It really took until September 2020 for us to get back on track with our screening rates where we were. So this graph on the right, what they're doing is comparing the data in 2020 to the data from 2018. So Breast Screen released their data every second year. So what we can see is that March, April, it dropped off a cliff, the number of screening that we were doing. And it slowly started to come back, but it really did take quite some time to get back to where we were expecting it to. The other thing we know is that in terms of returning to screening, people under the age of 60, people from Indigenous or culturally and linguistically diverse backgrounds, and people actually going for their first ever breast screen, they took longer to come back, partly because people weren't choosing to engage, but also the way that the Breast Screen Victoria or Breast Screen Australia have been prioritising. So people that are under 50, people that are coming for their first screen are not being prioritised. People that are coming for return screens are the ones that are getting appointments. So that first group, they're being waitlisted at present. So there is some inequities on both sides with that. Rural and remote areas, obviously access to breast screen services is limited. There's more reliance on mobile services, and it took a long time to get those services back on track. Cervical screening, lockdowns, less people got pap smears, so that's not surprising. People aged 60 to 74 less likely to participate in routine screening through COVID. Also looking at age groups and fear around COVID, it does make sense that older groups that were more at risk, if they did get COVID, were less likely to engage with their healthcare providers face-to-face. We can't really compare the data here because that 2-yearly release, during that previous data, we actually swapped from cytology to HPV virus testing. So it's not a direct link, but it gives you an idea of the trends of what was actually happening overall throughout COVID in terms of number of HPV tests. Bowel screening, the outlier. Oh, love it. There was no correlation between lockdowns and decreasing in testing patterns, which is good. That's excellent. Interestingly, there was less of an interval between people getting their kits and returning their kits. So people are at home, they're in lockdown. What are you going to do? I'm going to do my bowel cancer screening. They also changed the way and the number of invitations that they were sending out for bowel cancer screening. So again, the data is not completely reliable, but in terms of comparable, but you can get, again, an overview. Yes, it dropped off a little bit and picked up. Remembering with bowel cancer screening, there is also seasonality. They won't send out invitations to areas that are likely to have temperatures over 40 degrees because it impacts on the validity of the testing. So it is higher in winter and the cooler months as well. So why does all this stuff matter? Why does it matter if we're not screening and we're not picking up and we're not doing all this sort of stuff? So it is going to take years to see how this plays out. But if we look at historically what happens, women who were diagnosed with breast cancer through breast screen, less likely to die from their breast cancer than women that had never had a screen. Again, most cervical cancers we know are picked up in women who either aren't up to date with their testing or have never been screened. People who do their bowel cancer screening kits, 40% less likely to die from bowel cancer than those who either weren't invited to screen, so when they first rolled it out, or who haven't participated in their screening. We've seen with the data that Ralph has so kindly given us, even where there's that small change, we're going to see a lot of, financial and health impacts of that delay in screening. So, for example, when we look at the drop-off in screening rates for colorectal, we look at the reduction in colonoscopies, it works out at about 87,000 people that have had colonoscopies delayed in the last 18 months. That's a significant number of people that are potentially going to require more aggressive treatment. It's a huge burden financially and personally for the patients. We know that will also lead to poorer outcomes. You're going to have more people dying of bowel cancer because of that delay, which is a horrific thing to have to contemplate. So looking at the PHN and where we're at with our cancer screening. So this is data from 2018 that the PHN collated. So as a rule of thumb, you want to be closer to blue. Red means that your screening rates are really low. So we can see those big pockets where particularly cervical cancer screening, less so breast cancer screening, we're not hitting where we need to be at target. The graphs on the right do a bit of a comparison between Victoria, the PHN overall, and then we were looking at Wyndham and Brimbank because there's two focus areas where we know screening rates are slightly lower than the rest of the PHN. So we need to do a little bit better. Bowel cancer screening, again, you can see there are those big pockets where we're missing that screening opportunities. So looking at those catchment areas and looking at what we know about screening, have a think about what barriers you can identify both in your geographical area, but also within your own practice. So when we look at barriers, so we have patient-related and we have system-related. So I think patient-related is relatively self-explanatory, particularly when it comes to things like cervical screening and breast screening. People are embarrassed. There's cultural barriers, in terms of gender of healthcare provider, past history, particularly from people that are coming from backgrounds where they've experienced significant amounts of trauma. That's going to play a big part in their comfort factors in accessing screening. Confidentiality concerns, particularly around the use of interpreters. Particularly when you're dealing with those communities where it's quite a small community and the chances of them actually knowing the interpreter, that can be a significant issue. The other thing we need to look at is knowledge. So do people know why we screen? Do they know why it's important? Are they aware that potentially this could happen to them? Also, there is cultural groups that, not that denial is the option, but that belief in faith and things happen for a reason. So overcoming that and empowering them to take advantage of the opportunities that are available to be screened for these diseases. Personal relevance. Do they think it's going to bother them? Will I always use a condom? Well, that's not going to protect you from HPV. It's genital skin-to-skin contact. They've never been screened before. They've come from a country where they don't do screening. They're just too busy. They've got, 4 kids. They're looking after their mum. They work full time. When are they going to get time to screen? Are they worried about costs? You know, is bulk billing an option? If you're not a bulk billing clinic, is it something that you can look at from a QI perspective to increase your screening rate? Barriers, sort of physical disability is a big thing. Do you actually have the equipment that makes it easy and comfortable for your patients to engage with screening? If we look at a little bit more systemic related access, we're all flat stick with respiratory stuff at the moment. We know people are struggling to get appointments, and even just for things that they actually need done, this preventative healthcare has really taken a back seat just for lack of access. Do you have people in your clinic who can provide screening services? Are your staff aware of where your closest breast screen is? You know, do they know how to order bowel cancer screening kits through the website? The other thing too, obviously we've had some really significant changes, particularly in the cervical screening pathway. Are your healthcare providers up and across all the changes, and are they happy and confident in those changes so that they can confidently recommend that screening program to their patients? And then obviously the physical stuff, which, you know, if you're a newly built practice is really easy. If you're a retrofitted practice, potentially accessibility is an issue. Okay, so now we know what's happened. What are we going to do about it? How do we move forward? How do we actually engage these people? So first of all, looking at heart disease and diabetes. Okay. Ideally, in this age group, we should be seeing our patients regularly because the age-related risk factors start to creep up at around age 45 and younger if they come from an Aboriginal or Torres Strait Islander background. So in my practice, this is how I aim to engage with my patients. So before the age of 40, we're doing that SNAP profile. We're checking their blood pressure at least every 12 months. If there's an increased risk of diabetes, doing that screening as required, making sure that you're engaging with people and really getting them on board with preventative health before it's a really big thing that we're going to nag them about. So the earlier you start, the easier it will be later on. Remembering for people who are of Aboriginal and or Torres Strait Islander descent, the 715 health assessment runs from birth right to the other end. So they can be having that health assessment once a year at any age. For people from other backgrounds, so 40 to 49, you can claim a health assessment item to do a diabetes risk assessment. Once we get to 45 to 49, we move into a 45 plus health assessment, which is a once off only. Now, these all use health assessment item numbers. So remember, there are intervals of lockout periods of when you can claim these. So if they've had a diabetes risk assessment at age 44, you're then not going to be able to do their 45 plus health assessment until they're 47. Remember that lockout. Between 50 and 74, no health assessment items, but you can be doing that heart health check once a year. And then obviously once you get to 75 and over, you have your annual health assessment. So let's have a little bit of a look at these in more detail. So the 40 to 49 Oz risk check, it's really looking at their risk of type 2 diabetes and really engaging with people why their risk is where it is. For those people that are at high risk, so they need to score 12 in order to be able to claim the health assessment item. So on the right here, we can look at those non-modifiable, modifiable risk factors. So I think giving people an idea of what's putting them at risk that they actually don't have control over. So I think we've all had the patient that comes in, oh, you know, but I eat healthy and I exercise. It's like, yeah, but you're like a 67-year-old dude who was born in Southern Europe. Like, you're already at high risk, bam, straight from there. So really getting people to engage with the stuff that they can't change, to put weight on the things that they can. If they're scoring 12 and over, you can then claim a health assessment item for this. So the 45 to 49 deep dives a little bit more. So it's looking at chronic disease generally. So looking at lifestyle factors, their biomedical risk factors, their family history, again, engaging that thing. What can we change? What can't we change? What's in your power to do to reduce your risk overall? We know, and what I say to my patients is, the reason we do this health check at this age is that it's that time frame where things that are lurking in the family history, age-related changes are all starting to poke their heads up, and that we're going to start seeing the early effects of this. However, you are still young enough that you can make small, sustainable changes that have a lot of bang for their buck in the long run. We can make significant improvements by making the little changes now. What I say to my patients, nothing I tell you is rocket science. It's a reminder that doing the thing is the important bit, not just knowing that you need to do the thing. Okay, so 715 health check. More all-encompassing. So it's not only physical and mental health, we're also looking at social functioning. How are they living their life? Are we doing all that we can to support people to be healthy and to be engaged in their communities? We really want to close the gap more than we have. It's the disparities are just disgusting with our First Nations people. Now, with the 715, you ideally would do it once a year. However, there is a shorter interval. You can claim it at 9 months to work around finding for people. Once they've had a 715 health check, what that then opens up is a further 10 visits under the 10987 item. So if you think about your care plan suite and your 10997, so that little bonus extra that they get from engaging with your practice nurse or an Aboriginal health worker, that works in this similar way. So they've got those 10 visits so that things that have been identified within the health assessment can be acted on. They can engage with counselling, or they can engage with lifestyle education and lifestyle modification. It's giving you that incentive to really engage and get people's health where we want it to be. The other thing it does is open up their ability to get further subsidies on their medications under the Closing the Gap co-payment. Okay, heart health check, my pet project. I love this item number. It is just amazing. And people, if you do it well, appreciate it and will choose to engage repeatedly. So I'm now into, I think I'm now seeing people for their second and third heart health checks, so claiming it once a year. I look at the item. So the idea behind this is to address patients' risk of heart disease and implement a treatment plan to address their risk factors. I also continue to do an OZ risk score when people are coming in for this, because the two are closely related. The risk factors are very similar. It's keeping patients engaged with their risk with both heart disease and diabetes. You can claim this item as well as the other items. So you can do a 23, you can do a 721, 723. You can do that on the same day. Obviously, time-wise, it depends how you're going to go, but MBS will pay out for it. Part of this can be done by your practice nurse or an Aboriginal health worker. So they can do data collection, they can do your measurements. Generally, when it's passed over to the doctor, they will do the pardon my French, the Framlingham calculator and go through that sort of stuff. Again, if you're picking up things here, let's engage patients. What are we going to do next to address their risk? So you've done your OZ risk score, you've done your Framlingham calculator. Oh, my patient is at risk. What are we going to do about it? So the easy one is the medical side of things. If they have high cholesterol, treat it. If they have high blood pressure, treat it. Lifestyle stuff really comes down to what your patient needs to do and how we're going to make them do it. So if we think back to the risk factor increases over COVID, so people were stressed, people were bored, they couldn't go out, they couldn't do their usual things. What you've got there is a whole bunch of handles that you can grab and you can say, okay, well, you've said this, how are we going to address that to do this? Okay, so if you're stressed and that's why you're drinking, how do we manage the stress? You know, if you haven't been playing footy because footy was closed, new season, let's start, let's go. Okay, how are we going to get you fit and back up to where you were at? So, you know, come cricket season, you're ready to re-engage. There is so many resources out there, and obviously they're quite location specific. So I haven't really listed much. Care plans, we all know how to use them. They are fantastic. They are really amazing at getting people to engage, and particularly if you have really good people that you can, refer to, they're amazing. They're worth their weight in gold. If money is an issue, then community health centres, allied health, they run a lot of lifestyle risk reduction programs. So around healthy eating, around physical activity, a lot of them will run exercise classes, introduction to gym, those sorts of things. So jump on your community health centre web pages and have a look at what's on offer. Obviously, private allied health, so outside a care plan, they're not eligible for a care plan, but they need that intervention, refer them privately. Another great program, the LIFE program. So for people that are at increased risk of diabetes, or heart disease. It's a program that is either run as group classes or a one-on-one health coach over a 10-month program. And it's about motivational interviewing and getting people to reduce their risk of heart disease and diabetes. If smoking's an issue, getting them engaged with QUIT, getting them a QUIT counsellor, directing them to all the resources. And QUIT's amazing. The amount of stuff that they have available is phenomenal, absolutely phenomenal. Alcohol consumption is still an issue for some people. Do they need to engage with support, social work, rehab programs? Have a look at what's available and what you need. In terms of addressing the loneliness and mental health side of things, neighbourhood houses, I think it's really, we know men's sheds work because it's that side along. You're not going for the mental health benefits. It's just a bonus you get the mental health benefits. Neighbourhood houses, again, it's engagement and being social without the pressure of having to be social. Community social groups, Facebook, good karma networks, what's happening at your local library, talking to people about what do you enjoy. If I told you you had to go out and hang out with other people, what would you like to do? I have a 72-year-old patient that has taken up D&D gaming, and it gives me the warm and fuzzies, and I can see how much of an improvement that has made in his life. And, it was something that was completely off the cuff, spontaneous. What do you like doing? And it's had a real world impact. It's incredible. So don't be afraid to think outside the box and really have a chat with your patients about, I'm really worried that you're a little bit lonely after COVID. How can I help you? What can we do to get you back on track and get you feeling good about yourself again? So who are these people that we need to engage with? I love PenCat. If you've watched any of my webinars, you will know how much I love it. So first things first, let's have a look. Who's at risk of heart disease? In PenCat, there is a section down the bottom, and it's the cardiovascular event risk. And what it will do, it will look at your target groups and tell you who's got a risk calculated and what their risk is. But that lovely navy blue, who doesn't have that risk calculated and why? Are they missing measurements? Have we done blood? We've done a blood pressure recently. You can pick where you'd like to target. So if you want to do a really big QI push about getting those people in that don't know their risk, or you can focus on people that are at a high risk and starting to bring their risk down, this gives you the tools to be able to do that. The other thing we can look at is health assessments. Who hasn't had a health assessment? Who's not up to date? Again, there's a report for that down the bottom. The other thing we can look at is you can look by item number. So up the top under your filters, under MBS attendance, and what you can see here is I have selected that they have not had a 699 heart health check item. I'm looking in my target age group of 45 to 74, and down the bottom is my 820 patients that haven't had a heart health check. So that's a good place to start. The other things we need to look at is people that we know have diagnoses. We need to get them back and re-engaged with care. So who's missing care? Who hasn't been seeing their podiatrist? Who's potentially got diabetes because of all that snacking and all that not exercising they did during COVID? Whose results, they've come in, they've engaged with care, but their results are terrible and we need to get them where they need to go. Okay, care plans. So under the care plan item in PenCat, what it looks at is people that have diabetes, heart disease, or chronic renal failure or renal disease. So these are your target groups. They're not having their care plans. Why not? Are they paying privately for their allied health and we could be getting them a rebate? Are they just not engaging with allied health at all? This is a really good place to start. The other thing that we can look at is we can look at results. So down here, I've selected my type 2 diabetics and their HbA1c status. So again, you can see there's a small proportion of people that we don't have an up-to-date HbA1c. We can then also see where people are sitting at with their HbA1c. So again, are you going to target those people that aren't engaged, or are you going to target the people who are already sort of engaged and you just need to level up their care to get them at target? Cholesterol, same thing. We can look at that cholesterol. Who doesn't have it? Whose cholesterol's terrible? What do we need to do about it? We can also look at blood pressure. And this is a really big one, I think, given that we've done so much telehealth. Ideally, for just anyone who's an adult, we should be doing it at least once every 1 to 2 years, more frequently if they've got risk factors for heart disease. So this I've made a concerted effort now that we're seeing people face to face to pick it up. And I can tell you, compared to my statistics pre-COVID, people's systolic blood pressure is awful. So this is going to be a really good, easy, low-hanging fruit QI project for you if you need somewhere to start. The other really great thing that PenCat does, because it collates data, it can go through and pick up, maybe you need to look at these people because I think they might have diabetes, or I think they might have COPD or osteoporosis or renal failure, and it's not documented as a diagnosis. Part of this will be poor coding, so people freehanding diagnoses, people actually going, yeah, you've got diabetes, but not putting it on their file. So I've brought up the diabetes report here. So what it will tell you, and obviously this is the identified data, so it will give you your patient's name. It'll tell you when it started to pick up that it thought they might have turned diabetic. It'll look at, are they on medications? What was their HbA1c? What's their fasting glucose? What's their blood pressure doing? Do they smoke? You know, it gives you that overarching view. So you can see here, lipids are, that's a really good person to target because they're at much higher risk than anyone else in that list. So again, that's what, 1, 5, 7 patients. Start with that 7. That's all you need to do, and then work your way from there. So I've nagged you a lot. I've told you what you need to go forth and do. Health pathways, step by step, really simple, particularly if you are doing a clinic-wide QI thing, it gets everyone on the same page. They've got a heap there that you can jump on and have a look and pick something that you'd like to work through. Heart Foundation, they've got the Heart Health Check Toolkit, they've got patient education resources, they run walking groups, they have online exercise programs. You can actually write a walking prescription for your patient for a 4-week program tailored right to them. Diabetes Australia, I love their fact sheet. So if you wanted to have some more information about that and how to refer, you can jump onto their website and have a look. Okay, let's move on. Cancers. So I thought we'd just do a brief refresher of who needs what when. So breast cancer screening. It's recommended routinely every 2 years for people aged 50 to 74. Women and people with breasts can choose to start before the age of 50. As I said earlier, they are being waitlisted at present while they're trying to clear the backlog. The other thing to remember too, when we talk about mammography, what we're looking for is an area of dense tissue. So remembering in the pre or perimenopausal breast, the tissue is still quite dense. So you're looking for a density amongst a whole bunch of dense stuff. So counselling patients that if they are going for a mammogram before menopause, just letting them know that it's very common for women to be recalled after their first mammogram because A, we don't have films to compare it to, but also B, because of that breast tissue density. So just that reassurance, we want to make it an empowering, comfortable experience. It's not great having your boob sandwiched between 2 x-ray plates. Let's try and make women feel in charge and give them that control back. So 50 to 74-year-old cisgender women, we're also recommending mammograms for transgendered men who haven't had prop surgery and transgender women who've been taking hormones for 5+ years. That seems to be the tipping point at where the breast cancer risk starts to go up. For transgendered men who have had chest surgery, really liaise with their surgeons about what we need to be doing in terms of their screening. We're not doing routine screening for cisgendered men. So yes, 1 to 2% of breast cancers are in men each year, but for a screening population, the benefit is not there. Still counsel patients that any change in the skin or the tissue on the chest, particularly behind the nipple, needs to be investigated. So they need to come and talk to you about it. For transgender women, if they've been taking hormones for less than 5 years, at this point, there's no real role for routine screening, but certainly have that discussion with them about that tipping point and what to be looking for in terms of signs and symptoms. Bowel cancer screening, same age group, 50 to 74, everybody. Reasons they might want to postpone doing their screening during the menstrual period and for the 3 days after, just obviously we're looking for occult blood. doesn't tell between frank and occult. So we want to try and minimize that chance of getting a false positive. If they're having a flare-up of hemorrhoids, treat the hemorrhoids, get that bleeding under control, then encourage them to do their bowel screening kit. If they've recently had a colonoscopy, you obviously can get some bleeding. Or if they have acting PR bleeding and you don't know what's going on, obviously that's not a screening process, that now becomes a diagnostic process. I think we all fall into the trap of, oh, well, I'll just order an FOBT through pathology and that's fine, and perfectly legitimate, just the same, which is good. The benefits of actually ordering your patient a kit through the registry portal is that their follow-up every 2 years will then be taken over by the registry. So the onus isn't on you. The other thing too is we can't upload FOBT results to the bowel cancer screening register. So if your patient transitions care to somewhere else, their new healthcare provider can't just easily access their records through the register. So it is worth having a chat with the patient of, look, I'm going to order you a kit, it will come out in the post. Obviously, if they're asymptomatic. Cervical screening. So anyone with a cervix age 25 to 74, very excitingly, 1st of July, anyone who is due for a HPV test can do a self-collect. So it's your red pap flop swab, so dry swab, not the one in the medium. Obviously, if they're coming in postcoital bleeding, postmenopausal bleeding or intermenstrual bleeding, they need a practitioner-collected protest because it's a diagnostic, not a screening. So now that we've moved to self-collection, how does that look in terms of our flowchart? So I think the big thing is women have the option of a self-collection. They don't have to do a self-collection. Some women will still choose to have a practitioner-collected sample. The way I describe to women is we're going to do your HPV testing. If you come back with HPV, we would then do a traditional pap smear off the same sample. Yes, it's technically cytology, use language that the patient understands. Saying to them, if you would like to elect for a self-collection, that's wonderful, but just on the understanding that if it does come back with some HPV, you'll need to come back and see me or someone else to have a traditional sample. A lot of women will at that point choose, you know what, just do it and get it over and done with, because that way I don't have to come back. Convenience is key. I also work in Brunswick, so convenience is key. If you have patients that opt for a self-collect, if it comes back with HPV 16 or 18, you don't need to do the cytology. The cytology can be done at COLP because they're going to be given that referral anyway. If it comes back as a non-16, 18, they will have a liquid-based cytology with you, and then the flowchart flows on. Remembering for a non-16, 18 positive with either negative cytology or possible low-grade or low-grade intraepithelial lesions, their next test at 12 months is a HPV test. They can choose to do a self-collect at that 12-month follow-up as well. Remembering with that, now that we've gone to a 2 annual for non-16, 18 positive, remember that caveat of women over 50, Aboriginal and or Torres Strait Islander people, or women who were more than 2 years overdue for screening when they got that first HPV positive, they don't get that 3rd annual. They go directly to COLP after that 2nd. So have a look at the flowchart that's available on the council website and just familiarise yourself with those changes. So where are you finding your underscreened patients? So back to Pencat, she's a wonder. Under screening, you can look at your cervical screening, you can look at your mammograms, you can look at your FOBTs, and you can also look at vectors for osteoporosis, which is one I'm not touching on today, but I will be discussing in the next presentation next month. So cervical screening, who are you going to target? Are you going to target your people that have never had one? Are you going to target your people that are overdue? Are you going to target them all, depending on your numbers? I think particularly with the change to self-collection, I have been sending out text messages about, did you know a simple self-collected swab can help you prevent cervical cancer? Engaging with those people that are very anti-speculum, and we're all a little bit anti-speculum, but giving them and letting them know that that option is there for them now. If you are going through your data and you're coming up and you don't know what your patient's results are, remembering also you can access the National Cancer Screening Register through your Proto account so that you can check their screening history. So that is that lovely little blue box down there. When you open up your patient's screening history, So what it will tell you, so this is a cervical screening history, it will tell you when their last screening was, pardon me, it will tell you when their last one was, it will tell you when their next screening is due, alerts, so lovely little green one, that person had a normal cervical screening test, so their next one is just routine. If it's yellow, they're on elevated. If it's on red, well, they need follow-up and it hasn't happened, what's going on? You can look down at all their previous history. So if you click on the screening history button, it will bring up their entire history in a PDF format. In terms of if you've got patients who want to opt out of notifications or they want to opt out of a screening program, please encourage them, but they can. Or if you're looking at bowel screening and you're wanting to order a kit, that blue button where it says choose a form is where all that stuff happens. So in terms of what to do next, health pathways, if you know, it's been a little while since you've done cancer screening or you want to make sure that you're recommending the right things, health pathways will point you in the right direction. QI toolkits, if you think, yeah, you know what, we need to do a post-COVID cancer deep dive. There are QI improvement toolkits there. It's basically a document and you just fill it in and it will guide you through that entire process. You're engaging those patients that would prefer to have resources translated. Health Translations is a Vic government website. If you just jump on that website and type in screening, it will bring up all the screening in resources in alternate languages, which is helpful. Breast Screen Victoria, information about the process, and they also have online booking, so patients can create a login and just book in online. And Cancer Council, again, wonderful resources. So you have endured me and you've enjoyed listening to Ralph. Any questions or anything you wanted to know?
Well, look, I thought that was, I think you're on mute, Michaela.
Thank you. The things we still haven't learned after 2 years of COVID. I was just saying thank you, Natalie. That was a fantastic presentation, very in-depth, and lots of information there about the issues and the challenges and how to find those people and get them back in. Please feel free to pop your questions in the Q&A.
And while you're putting in your questions to the Q&A, Natalie, can you go back to the A1c slide on that you had for pen? Because, you know, I think, as like you have said, pen tool is a really fantastic tool to use. So, okay. So Natalie rightly showed you that you can actually, at a glance, see what's happening within your population. You can actually even pick those people who've not had a test within the last 12 months. So you can start thinking about, okay, who do I need to go to? Alternatively, as Nat said, you know, how to go about doing it. So you can see on this one here, she's got 6 people with an A1c greater than 10. Something's going on there. And you know that these people are going to feel unwell. Now, 6 people's not an overwhelming number. So you could say, I'm going to grab those 6 people, call them in, do a care plan, suss out what's going on, and do something about it. Because what you do there will have a huge impact on people's lives. And it's the same if you go to the next one around the lipids. The key here is that we often know that people who've had an acute event don't get down to target. So with pen, you can actually search under, you know, the health conditions, and you pick out people who've had an acute coronary syndrome, and then you look at people whose LDL. So you can see along the top there, you can actually look at LDL. Pick people who have an LDL greater than 2. I don't think you can do greater than 1.8 at the moment, but pick all those greater than 2, because you know they should all be less than 1.8. So these are simply, and what you might then do is, right, 5 people at a time, get my nurse to call them in, do a care plan, look at their figures. What am I going to do? What you do will save lives, because you'll intensify their statin, you'll prevent that second event, and that's just so critical. So I know sort of Natalie sort of glossed over this, but this pen tool is absolute stunning if you use it to your advantage. You would have to agree with that, wouldn't you, Nat?
I love PenCat. I am big ups for the PenCat. I can see that there was a little question. So it's PenCS is the program. It's available for free to accredited practices through the PHN. So you can give the PHN a call and they can put you in touch to get that uploaded. There are some really great resources on their website about how to use PenCat. I've done a number of webinars previously around flu vaccinations and COVID vaccinations that gets into the nitty-gritty of how you actually use PenCat in a little bit more detail. I don't tend to cover it too much in these because we have so much information to get through, but those resources are certainly there. Also, get in touch with your contact, your PHN contact. They can come out and they can organise one-on-one education with you about how to use PenCat effectively. And there's a QI toolkit for it too.
Now that is important. Look, there is a QI toolkit that you can download it from the PHN website, and I often refer to it in my talks. It is a step-by-step guide on how to implement change in your practice. And it does talk about what we call a quadruple aim. So not only improving outcomes for our patients, but also maintaining viability and sustainability of our practice. So a good tool to go with, and it hopefully will get you to an idea of not trying to do too much too quickly. So that's the real catch cry. Small amounts, because we're still in the middle of COVID, but an extra 5 care plans in a week will mean you'll save lives, you'll make money, and it won't be too onerous.
Okay, so in terms of, I can see there's a question, how do you access Proto to access the cancer screening register? I can't see what designation you are, if you're a nurse or a GP. So if you're a GP, you log into Proto and you scroll down and it's there. If you're a nurse, you can set up your own Proto account, access login. It's a pain, like everything else to do with Medicare and Centrelink, but it's doable. And you will have access. When you log in to the cancer screening register for the first time, if you are a practice nurse or Aboriginal health worker, you will need to have a designation like you do for HPOS of a healthcare provider. So have a chat with your practice principal and just say, look, I'd like to have access to the cancer screening register. Can you help me set up the delegation? If you jump on the Medicare, no, pardon my French, not Medicare, Centrelink website and look Proto access, then it has step-by-step guides of how to access that there.
So again, not a lot of questions. I thought by now people would be starting to think, oh, look, this is something important. How can we do this? And look, I must admit, and I'm sure Natalie would groan a little bit, but I actually tend to defer a lot to the nurses. I'll actually say, look, you know, I've got 20 people with an A1c greater than 7.5. I'm not happy. Or sorry, that's a cholesterol greater than 7.5. Call them in. Do a heart health check on them if they haven't had a heart thing. Let's talk about this because, again, you know, we know that there are a lot of people at high risk of heart disease that just aren't getting the treatment. And the beauty of the heart health check is actually focuses on those people who we know we can make a difference in. And the high risk, we will save lives, absolutely. Taking away the beautiful pen pictures. That's all right. We've had enough.
It's 7:55 on a Tuesday evening. You've all done very well to endure all of this discussion. So yeah, look, nursing and medicine, one thing is we always learn. So it's great that you see that, yep, there's a lot to do, but a little bit at a time, and the PHN has lots of supports if you want to actually get involved. That's really good.
I can see Natalie's replying to that question. PenCat works with most clinical softwares. It works best with Best Practice and Medical Director, but it does work with ZMed and Genie as well.
And I think, you know, to the person that's new to practice nursing, we're all new, and it's really hard to be at the novice end of the game, but that's why we run these webinars. Learn from my suffering. So you don't need to get everything all at once, and that's why I really like PenCat, is break it down into achievable chunks. You know, in terms of, if I pull up my cervical screening and I'm like, oh my God, I have 400 people that have never had a HPV screen. Break it down to smaller. Okay, let's target the 25. Let's target those 50 to 55-year-olds who are more likely to be having those cytology changes. Break your gaps, break it down and make it manageable for yourself. Pick something you're passionate about, you know.
Exactly. That's what I was going to say.
Yeah.
Because if you're passionate, you will do it, and you'll do it well.
And my doctors will tell you, I'm passionate about my QI-PIP stats. They hear about it every clinical meeting I run. It's like, where are we sitting? What are you people not doing? What am I not doing? Pick something that you enjoy, because the more that you achieve, and particularly when you're learning a new skill around quality improvement, and if you're working through a quality improvement toolkit for the first time, you want to be doing it with something that you feel like you've got a good handle on already. I like diabetes because they are a cohort that is usually relatively well engaged with their healthcare providers anyway. They're keen to see a podiatrist. You tell me another 75-year-old that doesn't want to see their podiatrist for their feet under a care plan. They all do. It's also things that, and you know, I like practice nursing because of the autonomy. I love that I can get a patient in. We can do their feet. I can do their blood pressure. We can have a chat about well, maybe don't buy Tim Tams would be wise. Like all those little things that you as a nurse have a lot of bang for your buck with. It's fun. It's so good. And watching your stats improve is so rewarding, because it's not just your numbers. You know how many of your patients are now experiencing better health and a better quality of life because of the effort that you put in. And to the person that said, would you like to come and hang out with me today? You're more than welcome, but there's a lot more swearing in my day-to-day life than there is on these webinars.
And hopefully not because of the doctors.
No, no comment.
Natalie and team and Michaela, I'm wondering if you can hear me. It's Marie at PHN also and listening in. And I just think that was fantastic, Natalie. And just a word about, I just endorse that QI element and bringing in your whole team. And I just love the way you used PenCat there, and Ralph spoke to it, how you can just drill down, find those 20 patients, and then as a team, as a QI, team, go, okay, we're going to pick out those 5 patients and call them in for a care plan, all that routine care, but you can get your reception staff in on it, that these appointments, when they come in, we'll code them with a little code that is, QI HR or QI, make your code that means something across your team so you all know what you're achieving when you're achieving it. I just think that's a fabulous way of, spreading that QI principle across the team, and everybody then gets to share in the joy of how great Pen is at drilling down, finding, and then following through with those patients.
Good.
Thanks, Marie. There's no more new questions. We might leave it there. Thank you very much to our presenters this evening for a wonderful, very informative session. And thank you to all of you for attending. We'll be sending out some more resources to you following the session, particularly some of those QI resources I think that we've mentioned in the session today, and where you can find some information on PenCat and Proto on our website. So thank you very much for the session this evening. I hope you have a lovely night.
Have a good one. Thank you.
Thank you.
Bye.